Thanks so much for being here.
Hey everybody, thanks for coming. My name is Steve Osterberg. I'm one of the general trauma surgeons at Barton. I am the newest one, so if you haven't seen me yet, I started in August. Excited to talk to you all about rib fractures and other things that can go wrong in the chest when you have a traumatic injury. I do not have any pertinent disclosures in case you're wondering. So, what we're going to talk about, what is in the chest, what can go wrong. So, what injuries might you encounter, how we can fix the common ones, and then what's the recovery like after that. Um, and if you have any questions, I'm happy to answer them at the end. So, starting off with a little general anatomy. What's in the chest? There's actually a surprising number of very important structures in the chest. Your heart and your lungs being the ones that you probably rely on the most and don't have to think about, hopefully. You have a tremendous amount of musculature and bones as well. There are 12 ribs on each side, bordered by your scapula, which is your part of your shoulder bone in the back, your clavicle, which sits up top. Um, and then two tubes that run through the back, which is your trachea, which helps you breathe, and your esophagus, which helps you eat and drink. You can see on this picture, and hopefully you can see my mouse, your ribs actually cover more than just your lungs. Your lungs kind of stop right here in the middle. Your ribs actually cover part of your liver, which is on your right side, and part of your spleen, which is on your left side. And that's going to be important later when we talk about breaking your ribs and what happens also. But this is kind of a big picture overview of the things that unfortunately can be injured in a traumatic injury. So a little bit more about the ribs because they're fairly important to us. You have 12 pairs, so 12 on each side. First through three are pretty well tucked up and pretty well anchored. Um, One through seven, you can see here actually connect directly to your sternum, which is your breastbone. It's a pretty thick bone that sits right in the middle of your chest and covers your heart. And then eight, nine, and 10, if you can see my mouse here, are below that. They connect via the other ribs. So they are kind of loosely connected to your sternum, but they're pretty mobile. And then 11 and 12 actually don't even connect to the front at all. They're kind of these floating ribs that sit in the back. Um, and then underneath each one of these ribs, there's a collection of nerves, arteries, and veins, which supply the blood and the nervous system to both the rib and all the muscles that are in between. And that sits right underneath each rib, which is pretty unique and becomes important later on. So, a little bit about why your ribs matter and maybe about how you breathe. Hopefully, you don't have to think about this very often, but when you take a breath in, you're actually changing the pressure inside your body with relation to the pressure outside the body. So when you take a breath in, the pressure is actually reduced inside your chest. So it's negative inside your chest. And so air preferentially travels from higher pressure to lower pressure or positive pressure to negative pressure. So when you take a breath in, you're not so much pushing breath in, but you're pulling air in. And then when you breathe out, the opposite happens. So the pressure becomes more positive inside your chest. And so air gets pushed out. So you pull air in and you push air out. And the only way that happens is because of your ribs and your diaphragm. You can see in this picture, the diaphragm moves down when you breathe in, it creates more space, and it moves up when you breathe out, creates less space. Um, so that's a little bit of kind of physiology of how you breathe, and that becomes really important when we talk about what can go wrong. So a little bit more about the ribs. This is getting into the nitty-gritty, but I find it really fascinating that your ribs all actually move in different directions when you breathe. So the ribs that are higher up on your rib cage, when you breathe in, if you are a visual person or a tactile learner, if you take a deep breath in right now, you can feel that the top part of your chest moves out and up. And so that increases the anterior posterior diameter of your thoracic cage, or basically creates more space between the front and the back. And then your lower ribs, when you take a breath in, they actually move out a little bit. They flare out. So that creates more space left and right in your chest. So while they're all connected, they have different roles, especially when you're breathing. Um, and there's this muscle layer between each rib. There's actually three muscle layers, but between the first two layers, that's where the nerve, artery, and vein that I talked about before for every single rib is located. So it's somewhat protected from the outside world. It's got this extra layer of support from the muscles, and it's tucked underneath the rib. So it's designed to protect these structures from injury. This is a little better picture of this. If you can see my mouse, you can see that this is the rib here that's running. It connects your sternum all the way back to your spinal column. And the nerve, artery, and vein, they run right underneath the rib. This picture is the one below is a little deceiving, but that is actually not above the rib, it's below the rib. So there's this connection between the blood vessels and the nerves all the way around, which gives extra support. And you can see that these ribs connect, like I said, back here to both the spinal column in the back and some of them to the sternum in the front. So your chest wall is very interconnected, and while all of these ribs have a slightly different function, they all function together for a single purpose. So when we talk about injuring parts of your body, what's a common ways we see that? So usually this is a high force incident. So a motor vehicle collision. Usually we see this if they're traveling more than 40 miles per hour. Any type of fall, whether it's walking down a driveway, falling down a mountain, um, anything that has a significant energy behind it. Any rapid deceleration mechanism. So if you are skiing or snowboarding and you come to a sudden arboreal stop because you hit a tree, that would be a rapid deceleration mechanism. And then less likely is penetrating trauma, a gunshot wound or a stabbing, we those tend to be focal injuries to softer organs. They usually don't have a significant destructive power to a large number of ribs or the spine. They can have a focal deficit, especially the spinal column. But we're talking about a big injury to your chest wall. We see that more commonly with a blunt mechanism of injury than with a penetrating mechanism of injury. So this is a little scary and a little terrifying. This is a whole list, a small list of a whole lot of things that can go wrong in your chest. So when someone comes to the emergency department with a traumatic mechanism of injury, these are the small number of the things that I'm worried about. Anywhere from, pretty much anything in your chest wall can get damaged. So we talked about the diaphragm, we talked about the chest wall, scapula, your ribs, your esophagus or your trachea. There's a lot of very important blood vessels that run through your chest. That injury to those can have pretty devastating consequences. And then hemothorax and pneumothorax, we're going to talk about that in particular a little bit later on, but hemothorax is blood building up in your chest. Pneumothorax is air building up in your chest, and usually that's a result of damage to your lungs or the blood vessels around your lungs. Um, your spine, your clavicle, so important. I put it on there twice, and your heart. Usually, if you have a blunt injury to your heart, those can be fairly devastating, and we don't see those injuries as often, thankfully. So a little bit about lung trauma. We're going to talk about this more later, but your lungs, as we saw earlier, are fairly large organs. They take up a majority of the space in your chest. And when we get an X-ray, what I'm looking for is either air or blood outside of the lung. if you look at my cursor here, if your screen is big enough, there's a small little line here. This is actually a X-ray of someone that had a blunt chest injury and has a large pneumothorax. So all of this kind of blank space over here is air, and it's actually collapsed the lung and shifted everything over. So that's a pretty significant emergency. That's kind of on the one end of the spectrum of lung injuries. On the other end of the spectrum is something called a pulmonary contusion, and this is just bruising of the lung, like you would bruise any other part of your body. But when you bruise part of your lung, if you bruise a large enough part of your lung, it can significantly impact how well your lung works. So we take all of this pretty seriously. So rib fractures. These are one of the more common injuries we see, which doesn't mean that they're insignificant, but unfortunately means we get pretty good at taking care of them. We see them in at least a tenth of trauma patients. It's the most common injury we see, and usually these are associated with other injuries because if your body absorbs enough force to break ribs, it's often going to damage other structures that your ribs are trying to protect. Um, the most common ribs that are injured are 4 through 10, which, if you think back to that picture we showed earlier, those are the ones in the middle. They're the ones that directly attach the sternum, but they're not as mobile as like 11 and 12, which are the floating ribs. Um, and depending on which ribs are fractured, you might injure other organs as well, like your abdominal organs, your liver, your spleen, major vascular structures, or your lung. Um, but the problem with rib fractures is usually they're fraught with complications. So if you have an injury to your ribs, there's a good chance that there's other things that are going to go wrong, and that's really where the challenge in managing rib fractures comes from. So getting into the ribs a little bit more in depth, I like this picture because it really shows the depth and the intricacy that every bone in our body has. And where you break the rib has a very significant impact on your healing course. If you break the rib um, far outside here on the most lateral aspect or closer to your scapula in the back, that can be pretty painful because there's a lot of mobility that happens when your ribs move there. If you break them closer to your sternum, um, here or closer to your spinal column here, those are a lot more well fixed. They have less movement with every breath. So it usually doesn't have quite as much pain. But where you break the rib, how displaced or how separated the two ends of the ribs are, and if that rib, when it breaks, changes the normal angle called angulation, that can have a big impact on your pain and how well your chest wall moves, and thus how well your lungs work. So every rib fracture is not the same. So when patients come in and they have a significant chest wall mechanism of injury, there are some key symptoms that I'm looking for that make me think that there might be a rib fracture or some other significant trauma going on. So usually you have severe chest wall pain. You likely might have some difficulty breathing or shortness of breath. You might also have some abdominal pain because those ribs that we saw earlier don't just cover the lungs, they cover some of your abdominal organs. And your chest wall might not have the normal structure and function that it's supposed to. So we might see some instability. This is a 3D reconstruction of a CAT scan, and this patient, I think the medical terminology would be has a trashed rib cage. They have uh, pretty significantly displaced rib fractures. So you can see here they're overlapping pretty significantly. There aren't very many that are just fractured and lined up pretty well. in some spots, kind of hard to tell exactly which rib goes to which. When I look at an X-ray or a CT scan like this, oftentimes it's easier to count the ribs that aren't broken than the ones that are. But newer imaging technology has given us a lot more information about how um, the rib fractures will affect your outcome. So this is a great tool that we use almost every patient that has significant chest wall trauma to get a better idea of what exactly is going on. So we talked about rib fractures in general. There's a subset of rib fractures that is even more severe. So if you have three or more ribs, and each of those ribs is broken in two or more places, that actually disconnects that part of the chest wall from the rest of your rib cage. It creates something called a flail chest. This is the most severe form of chest trauma that we see. These patients um, are pretty sick. They have a pretty bad problem. They're likely going to have significant alteration in how their lungs work or their pulmonary mechanics. And they're probably going to need extra support, whether that's just supplemental oxygen or it may be so severe that their chest wall doesn't work hardly at all, and they actually need to be supported with a breathing machine, which requires something called intubation, where you put a tube down your throat into your lungs, and we actually mechanically inflate and deflate your lungs. And the reason this becomes such a problem is it creates something called paradoxical chest wall movement. I'm going to show a short video that is not terribly graphic, but it's definitely going to be a little shocking. So as this patient breathes in and out, you can see that this part of the chest wall collapses and then reinflates. Um, when you like we talked about earlier, when you take a breath in, your ribs move out, and that creates negative pressure inside your chest, and air rushes in. Well, when you have a flail chest and no, stop playing, keep playing. When you have a flail chest and you take a breath in, that section that's disconnected from your chest wall, it's going to go where the air is going. So instead of all of your ribs and your chest wall expanding outward and air rushing in, part of your chest wall is actually going to get sucked in with the negative pressure. So that's what that video showed. Let's see if I can play it one more time. You can see right here, this chest wall is collapsing when it's supposed to be expanding. Um, and, and that can be pretty devastating to your pulmonary mechanics. So we talked about the ribs as the most commonly broken bone in the chest. Your sternum requires even more force to break, and it has a similar problem because it's connected to your ribs. So it has movement during inspiration and expiration, and that can be also significantly painful. And the problem is if you break your sternum, if you direct all this pressure to this bone right here, there's a good chance that you could injure whatever structure is sitting right behind your sternum, which is your heart. So you have a high risk of having a blunt cardiac injury, which can be lethal. Um, and when we see a fracture in the sternum, I always look for injuries in surrounding organs. This picture right here on the right side of the screen is a CAT scan image that's targeted to look at the bones. It's what we call a sagittal cut, which basically means these images are taken tangentially right through the middle of your body. So this is in the back is your spinal column, in your front is your sternum, and in the middle right here is your heart. What there isn't an arrow pointing to is back here. You can see right here, there's a very significant vertebral body injury with significant loss of height. There's actually a little piece of the bone that's been pushed into the spinal column. So that's not uncommon for me to see. If there's enough pressure and force to break your sternum here, the other large structure back here that's also going to absorb that force is your spinal column. So this is the injury pattern that I see very commonly and can be very challenging. So how do we find these problems? What can you expect to happen once you come to the emergency department? So if you have a significant mechanism injury, you almost always are going to get something called a CAT scan. And that is a picture that we see right here. This is the standard way that we get a CAT scan. These images are all coming up and down. And in this picture, what I would imagine in my head is looking through the center of a body with the feet pointing out towards the screen and the head coming out towards me. Um, the chest x-ray is usually the first thing that we get. It's easy, it's very inexpensive. We can look at things right away. That only catches about 50% of rib fractures, though. So it's fairly unreliable. If it's positive, it's usually real. But if I don't see rib fractures on an x-ray, it doesn't make me feel any better about it. So the next thing we get is usually a chest CT, which is this. This particular chest CT has a lot of very concerning findings. Just some major landmarks here. Right in the back, right here is your spinal column. In the middle is actually the top of your heart, where the pulmonary vessels are. Right in the middle here is your trachea. Somewhere squished on the side here is your esophagus. And these big, they look spongy to me because that's what I expect them to look like, are lungs on each side. And this dark black area outside of the lung is actually air that's trapped inside the chest cavity, outside the lungs, and it's collapsing the lung. The lung should fill this whole space, and it's not. And this area that's much brighter, this is actually either blood and or a pulmonary contusion where the lung is bruised. And then there's all this air in space it's not supposed to be. So we call this pneumomediastinum. This is air surrounding the heart. That's not good. And then there's air actually in the chest wall musculature, which means there's so much air here that it's found any other place that it can escape and push out to. So this picture is of a patient that has pretty severe chest wall trauma and is definitely going to need intensive care. And then other interventions or other tests slash interventions that we would do an EKG, which looks at the electrical function of the heart if I'm worried about a blunt cardiac injury. And then endoscopy, which would involve putting a camera either into the lungs or into the esophagus and stomach or both, because there's enough force in the chest to produce this type of picture. I'd be very worried about, in addition to the lung trauma, a blunt tracheal or esophageal injury. And the only way to really rule in or rule out that definitively is actually going and taking a look ourselves. So we have a lot of tools that we can use to try and find the problems. So what things am I looking for that would require you to either stay in the hospital or to get intensive care or to be discharged home? So these are these are all things that are going through my head when I'm taking care of patients in the emergency department. So if your respiratory rate is really high, that is a sign that your pulmonary mechanics may be altered. Your lungs aren't exchanging gases as well. That has a high risk of leading to respiratory failure, which is not something that you want to associate with. If your pain is really high, if your cough is weak, if you have more years under your belt, or if you have a significant number of fractures, I'm probably going to want to keep you in the hospital. If you are more senior in age, you have a higher risk of complications from rib fractures, even one rib fracture. So I would probably want to watch you closely in the ICU. If you have more than six fractures, I'm definitely going to keep a close eye on you. If you have flail chest, like we saw earlier, you have a high risk of pulmonary failure. So I'm going to watch you closer if you're needing extra oxygen, or if you have other serious traumatic injuries that also need care. Those are all um, criteria that I would want to apply to your admission. So what other things do we see with rib fractures commonly? We see injuries to the lungs most commonly when we have rib fractures. And that's for two things. A, just the amount of force that's directed toward the chest can just cause blunt lung trauma. But B, when you break your rib, that rib now has two sharp ends that very commonly can poke into and or tear your lung. Your lung is like a giant sponge, but it tears very, very easily. So if you just poke into your lung and you release a little bit of air, that's called a pneumothorax, air surrounding your lung. It's usually not a big deal unless you get a lot of air that's escaped your lung, and that can actually compress your lung so much that it doesn't work. That can be called a tension pneumothorax. This x-ray here is actually a patient that has hemothorax, which is blood inside your chest. And so the left side actually looks pretty okay, except there's this tube in the middle and there's this hazy area that's not supposed to be here. And that's because on this other side, it's almost totally whited out, which can be from a lot of things, but usually in the setting of trauma, that's blood filling the chest and actually pushing everything over into the other side. So this is supposed to be in the middle here, but it's gotten pushed over because there's so much blood in the right chest. That's very common um, when you have significant rib fractures. And then a liver or a spleen laceration. That's because your ribs also sit over your liver and your spleen. So if you break those ribs, they can either A, tear into those structures, or B, more commonly, there's just enough force to that area that it also lacerates that organ underneath your rib. So if I see, ribs number 8 and 9 or even 10 fractured on the left side, I'm going to have a higher suspicion that you might also have a splenic injury. So, in addition to just having these ribs that are broken, um, there's other things that can go wrong after you have these fractures. And the problem is if you're older, especially if you're older 65, your complication risk is much, much higher. That's why I admit those patients to the ICU. So your risk of overall mortality and pneumonia is significantly higher than with younger patients. Pneumonia is the most common complication we see from rib fractures, and it's also the most common thing to lead to death after rib fractures. And that's because that lung is more susceptible to disease, and it's also not working as hard. And so it's more susceptible to disease after the injury. Other things that can happen, retained hemothorax, that's if you have blood that gets built up in the chest that never gets released, that can become infected and cause an empyema. Respiratory failure, where because your lungs and your chest wall are so damaged, they don't work as well. And then later on down the line, if those fractures don't heal up, that can be called fracture non-union, which is pretty troubling. You can get clots in your deep veins from either the initial trauma or immobility after trauma that can spread to your lungs and called a pulmonary embolism. That's where blood clots block flow of blood to the lungs. That can be lethal. And unfortunately, because these rib fractures are very painful and you saw how they're surrounded by important nerves, the risk of having chronic pain from rib fractures is fairly high. It could be even up to 50% in some patients. So, what do we do about these rib fractures and other chest trauma? How do we fix this? Um, Oftentimes, these do not require surgery, but there are a lot of other things that we are doing in the background to try and help you heal. So pain control is a huge part of the game. If we can, taking pills by mouth is going to give you longer term pain control. But sometimes you need immediate access, and that is where the IV medications really work well. And we've gotten better and better at using nerve blocks in different spaces, either between the nerves, back behind your nerves, or even an epidural, which is what we use in other settings. All of this is just trying to target the pain receptors so that you don't have as much pain because every time you breathe, you're going to feel those rib fractures. Oftentimes, we need supplemental oxygen because your lungs aren't working as well. They're not exchanging gas as well. And then pulmonary therapy. This with pain control are the two things that I harp on more than anything else for recovering from rib and chest trauma. And so that might be something called an incentive spirometer or an acapella. These are devices that you breathe in and out of that help you take deeper breaths. And deeper breaths are going to activate more of your lungs and that are going to promote healing. And then sometimes, if your lungs just aren't working enough, you might need breathing support, like mechanical ventilation that we talked about earlier. But that comes with the caveat that if you're getting mechanical ventilation, this is artificial ventilation. It is not how the lungs are supposed to normally operate. So your risk of pneumonia increases every single day that you're using getting that mechanical ventilation. So while sometimes this is necessary, it is definitely not ideal. So these are kind of the tenets of our initial way to manage rib fractures. But something that I find very valuable in the right setting is surgical fixation. And so this in other settings is called ORIF, or an open reduction internal fixation. And so where we go in and we basically realign the ribs and then put some sort of device in to keep them aligned while they heal. But we don't do this for everybody. We don't do these for just a few isolated ribs that are in the back, if you're not having significant pain. But there are scenarios where this can have real benefits. So patients with that flail chest, where they have a disconnected segment of their chest wall, we got to reconnect that segment. And so that's one of the classic scenarios where we do surgical fixation. If your rib fractures are so severe that your pulmonary mechanics have failed and you're in respiratory failure and you need that mechanical ventilation, you would benefit from rib fixation. If you have three or more ribs with displacement, so you might not necessarily meet criteria for having a flail chest, but you've got three or more ribs and they are not lined up at all. You have a high risk of eventually having fracture non-union, and so we think those patients would benefit from fixation. So why would you fix these ribs? What are the benefits? Um, so a lot of this research has been done over quite some time, and the way we fix ribs today is very different from the way we fix ribs 10 years ago. And so a lot of the studies are challenging to interpret because of that issue. But in general, we see fewer days in the ICU and in the hospital with patients that get their ribs fixed. You have fewer days requiring mechanical ventilator support, and you have a decreased mortality. But the caveat to this is there's a lot of different ways to fix ribs that are being studied and trying to be lumped together. And oftentimes, a lot of these studies are being paid for by companies that make the technology to fix the ribs. So there's a not insignificant conflict of interest. Um, so there's also a fair amount of anecdotal support that comes from this. Um, but we see surgical fixation becoming more and more popular in these severe trauma patients. But when you fix them is just as important as if you're going to fix them or not. And the earlier you get your ribs fixed in your hospital course, the better your outcomes are. The longer you wait, the benefits get smaller and smaller and smaller. So we try and identify these patients that need fixation early and do their surgery early. These are a few pictures of what that looks like. So this is actually a fairly large incision for having your ribs fixed. But you can see up here, this is actually a metal bar that we've drilled into the rib itself after we've realigned it. And this right here, there's two instruments that are trying to reduce this fracture and line up these ends so that we can put a plate on there. The two most common ways that I fix ribs are internal and external fixation. So external fixation is a bar that goes on the outside of the rib, like here, like this one here. I don't put nearly that many screws in, but you could. And then internal fixation is this picture on the top right. That's where the bar is actually on the inside of the rib instead of the outside of the rib. This is a picture of a patient that had severe rib fractures with significant displacement. I think the counting might be a little off though, but you can see this is a common way that I fix ribs now. I make one incision, and with newer technology, I'm able to access ribs that are really high up. Um, Sometimes you have to make an additional incision up over the scapula to get to these ribs, but usually I can get 6 ribs fixed through one incision. And so this is an X-ray taking in the middle with the hardware already in place with the ribs lined up. So another device that you might encounter if you have significant rib trauma is something called a chest tube. So if you have a lot of air or blood built up in your chest, there's really not many ways that can get removed. If you have a small amount of air, small amount of blood, the body can slowly reabsorb that over time. But you have a larger amount, you have a high risk of either it A, causing respiratory failure, or B, eventually getting infected. So we try and put a small tube into your chest. This is something we can do at the bedside in the operate or in the ER or in the operating room, to basically get that air and blood out. The tube is anywhere from the size of your thumb to the size of a pencil. It kind of depends on the scenario. And it's get connected to this little box on the right side called an atrium that basically protects anything from getting up into that tube, but allows that tube to drain everything out. Usually that tube would stay in for 2 to 3 days, ideally, sometimes longer, depending on how severe the trauma is. But it's not a particularly pleasant experience. Like we said, there's a lot of nerves that run through your chest wall, and when a tube is um, in your chest wall, it often irritates those nerves. So we try to put this tube in only if you need it and leave it in only as long as you need it. So this is a picture on the left side of a patient that had a pretty significant pneumothorax. It's kind of hard to see, but my cursor is going to outline the edge of the lung, which, as you can see, is significantly farther away from the rib, uh, from the outside of the rib cage than it's supposed to be. So all this space in here is a lot of trapped air. So that trapped air is probably from this lung getting lacerated, and air escapes. Usually that hole seals up right away, but sometimes that hole doesn't heal up right away. And every time you take a breath in and out, air seeps out of the lung and gets trapped inside the rib cage. Your chest wall, while it has a fair amount of mobility, is still a fixed structure. There's only a certain amount of space in there. And if the air is taking up that space, it's going to win over the lung. So this picture on the right is what your chest would look like with a chest tube inserted. So this tube right here comes in through your skin, goes right above your rib, and then sits in your chest and evacuates ideally all the air and or blood around there. So we've talked about what can go wrong, how we can fix it, what are the tools we use to fix it, what's the recovery that you could expect after a significant chest wall trauma. Well, specifically for ribs and your sternum, these usually take 6 to 8 weeks to heal. So it's a long process. It's not going to get better overnight or even with a few weeks. Your pain and your function should continue to improve week after week, but it's definitely a long game. And the biggest part of your recovery is your mobilization. So you've got to be up, you've got to be moving around. You have to be using either that incentive spirometer or your acapella or some other device to kind of continue to exercise your lungs, because when your chest is damaged, that side is not going to want to work as hard, because every time you breathe, those fractures are going to irritate the muscles and the nerves, and it's going to be very painful. So your body, consciously and subconsciously, is going to not use that as much as it should. And that's going to lead to you getting an pneumonia or some other complication. So using those lung exercises and moving your body is going to be key. And just as important with that is pain control, because rib fractures are painful. There's little we can do to avoid that. Even if you get surgery, you're still healing an incision now. So it's still going to be painful. So we use what's called a multimodal pain regimen. There's no magic bullet for pain control. We use usually 3, sometimes up to 5 different medications that all work together synergistically to reduce your pain level. So if you're someone that says, well, Tylenol or Advil, it doesn't work for me, well, it might not work for you by itself, but with other medications, with a muscle relaxer, with a nerve medication, all those medications working together will reduce your pain level. It's not going to take it to zero. It's just not possible. We use stronger pain medicines like oxycodone or Vicodin, but I try to avoid these as much as possible. Some of them are necessary and they have a role here, but the higher dosages of these pain medications is going to lead to other complications. I'm gonna I'll stay off my soapbox about opiates, but in general, I tell people that they are made by patient they are made by companies that want to make money, not necessarily want to make you better. So I try to avoid these as much as possible. If you have a pneumothorax or a puncture in your lung, I don't want you traveling on an airplane for a couple weeks. This is because the changes in pressure up and down could potentially cause that tear in your lung to reopen. But there's been a lot of research done on this, and usually after about 2 weeks, you are in the clear. And some people require physical therapy afterwards, and that's just because the damage to your chest wall affects all the other structures that are attached to your chest wall. So your clavicle, your scapula, your arms, your neck, they're all interconnected. You break one part, it's going to affect the other part. So sometimes having outpatient physical therapy can be really beneficial to the healing process. So, some kind of overall summaries or quick hits about what we talked about. Um, the chest wall is one of the most commonly injured structures, and the ribs are usually the ones that are injured in that setting. But like we talked about, there are a lot of other things that can injure there. Oftentimes, we manage rib fractures without surgery. In general, if you can avoid surgery, it's probably a good thing. We try to balance. Um, I want to find a scenario where the treatment isn't worse than the disease. So I don't want to make you worse with a surgery just because it makes your ribs look better. So if I find the right scenario, then I'm definitely going to offer you surgery, but it's not going to be for everyone. Um, but rib fractures usually don't happen in isolation. So we have to treat the associated injuries and be ready for the complications that can come with them. Um, but unfortunately, the recovery from chest trauma is usually long and painful. But the most important thing during that process is to stay active. Sitting on a couch, staying in bed all day because it hurts is just going to make things worse. So, if people are telling you to get up and move and breathe, it's not because we don't like you. It's because we know that there are serious complications that can happen from these injuries, and we try to avoid them. These are some references, and that is all I have. If I hope this has given you kind of a bird's eye view of chest trauma and given you a little bit more helpful information on rib fractures in particular. And if you have any questions, I'm happy to answer them.
Great. Thank you so much. We have gotten a couple questions throughout, so I'll kind of ask them as they came in, and some might have been addressed, but it's always good to get them re-answered. The first one, and just as a reminder, I'm sorry, if you do have a question, you can ask in the Q&A box located at the bottom of the Zoom screen or in the chat. But the first question is just asking about, sounds like a friend fell on the ice and had pain in their lower right rib. They went to urgent care. They were told they probably had a rib fracture and needed to give it time. Are there symptoms that they should be on the lookout for to help determine if they have a rib fracture and whether they should go to urgent care or the ER?
That's a great question, and it's hard because if you fall and you break one or two ribs, you probably don't need to come and get admitted to the hospital. You probably are going to be okay. Um, but if you are short of breath, if you cannot take a deep breath in without really significant rib pain, and it doesn't get better with Advil or Tylenol, I'd probably want to see you in urgent care or the ER. If your pain seems like it's spread, if it was in one spot, but now it's like your whole chest, or now your abdomen, your belly is starting to hurt, that's another really important warning sign. And if you have that, you get an x-ray or someone tells you you have a rib fracture, it's just one rib fracture, you'll be fine, it'll get better in a few weeks. But then after a week or so, you have a fever and you have a productive cough. Now I'm worried you might be developing a pneumonia or an infection. So that's another one of those most common complications that I want people to be on the lookout for, even if they've been told they have a rib fracture.
Great. Let's see. The next question. I broke some ribs earlier this year. It was really painful to laugh or cough. Are there interventions? I know you mentioned some at the end, but that can help with healing or decreasing discomfort.
So, with the pain for rib fractures, the key is to take pain medications before a lot of that severe pain kicks in. And that doesn't have to be the strongest pain medicines like oxycodone or Vicodin. Taking those multimodal pain medicines early and often can help decrease that pain before it becomes so severe that you can't do anything else. So doing that early on in the recovery process is key. And then week by week, hopefully, you're able to slowly decrease the number of pills you need during the day. You might be able to go during the day in general without needing that pain medicine, but you just need it at night because it's uncomfortable to sleep on them. So that's the first key component. And then the second component is doing pulmonary exercises. So the devices that I talked about are are a great adjunct. But the other thing is just focusing on taking slow, long, deep breaths. I tell people to take 10 of those breaths an hour, 10 hours a day. So 10 and 10. And that's going to help speed up that pulmonary strengthening because all this is A, helping you heal, and B, preventing I don't want you to have a significant decline. My goal is for you to stay the same and then slowly get better and not have an injury and really take a deep step back because then that's a much harder hill to climb later on.
The next question is what are some of the most common causes of pulmonary embolism?
So it depends on versus a non-trauma patient. But in general, anything that promotes immobility is going to have a high risk of forming a blood clot in a vein somewhere else in your body and then traveling to your lungs. Um, so we see that commonly in trauma patients because if you have a lot of injuries, you're going to be a lot less mobile than you would if you go in for even elective surgery. That's going to have a period of immobility sometimes, and it's going to put you prone to having a blood clot that can travel to your lungs. And then we also see it commonly in patients that are traveling for long stretches. So long haul truckers, extensive, long airplane flights where you're immobile for long periods of time. All of that is going to promote kind of what we call venous stasis or blood sitting and pooling in one area that can then form a blood clot and then travel somewhere else.
When it comes to first aid of chest injuries, is it safe to do CPR?
Yeah, that's a really good question. Um, if you are in a scenario where there is such significant trauma that your heart stops beating, your lungs stop working, you don't have a pulse, then the rib fractures are going to be a secondary concern. Unfortunately, if you're doing high quality CPR for a long period of time, you will probably break ribs. But rib fractures we can heal and fix down the line. If your heart stops beating and your lung stops working and they don't come back, well, we can't fix the ribs later on. So life is key. And if someone had significant rib trauma, I'm worried about a blunt cardiac injury or um, a blunt pulmonary injury, but starting high quality CPR and getting them to the emergency department is going to be the most important step in their recovery.
Great. Why can't a oh gosh, I'm not sure if I'm going to say this right. The pneumothorax be
Mhm.
life-threatening?
Why can it or why can it?
Yeah,
Sorry.
why can it?
Why can? Oh yeah, it's a good question. So as the chest wall, I'm going to go back a million slides. So in the chest here, this is a very mobile structure. We talked about how the ribs move in different directions to create more space in the chest. But the amount of space in the chest is still fixed, even at the best scenario. So your lung needs to be this big to really function. If there's air in here and it causes this lung to collapse, there is less surface area inside the lung for gas exchange. So its functionality decreases rapidly. And if that happens on both sides, well, then you're not doing any gas exchange and you're going to go into cardiac arrest. So that's one of the problems. The other thing is if you have so much air that builds up inside the chest wall, that's going to start pushing pressure on not just the lungs, but the heart and the blood vessels that are in the chest. So that pneumothorax, that air trapped in the chest, that pressure can actually cut off blood supply to the heart and the lungs. And if that can also lead, that can be a fatal event. And so it's a gray area on exactly when the best time is to put in a chest tube. How much air is too much air? Most emergency doctors and trauma surgeons are fairly conservative. And if we can see enough air in your chest x-ray that's tracking down the side of your chest wall, then that's too much air. That's probably going to get worse and not get better. So that patient would definitely benefit from an intervention. So when to intervene is a little bit of more art than science. So there are some scenarios where a pneumothorax wouldn't be life-threatening. But in general, we try to avoid a non-life-threatening injury becoming a life-threatening injury.
Great. I think that is starting to wrap up the questions. I just thought I'd ask if you wanted to share a little bit more about your practice and how patients might be able to see you. And we'll wrap it up after that.
Awesome. So I'm a general and trauma surgeon. I trained in Atlanta, Georgia, so I took care of a lot of trauma patients, but I also did a lot of robotic surgery. So my practice has a lot of very complex components all fitting together. So I take a lot of trauma calls. So I take care of a lot of trauma patients that come into the hospital. So you might see me in the emergency department if you meet the ground or a tree or another car unexpectedly. Um, but if you have an elective problem, if you have a gallbladder problem or a hernia or a colon or breast cancer, those are problems that I take care of through my office, which is across the street from the hospital, on a daily basis. And then we'll schedule you for your outpatient surgery. And then the third piece is to do a lot of endoscopy. So upper endoscopy, where we put cameras into people's stomachs to look for ulcers or cancers, and also colonoscopies to either screen or treat any diseases of the colon. So if you need a screening colonoscopy, that's something that I do on a weekly basis, and everybody in my office does that as well.
Excellent. Well, I have not seen any other questions come in, and we're almost to the top of the hour. So that was great. I do see some really nice comments. So much appreciated the topic tonight. Just for those of you who want to review this, we will have it posted to our YouTube channel, as well as on our Facebook channel. And there is a survey at the end of tonight's webinar that we would love your feedback, how we did, and what topics you would like to hear from us in the future. But I think with that, Dr. Osterberg, I don't see any other questions, and I'll go ahead and say goodnight. So thanks so much for being here. Appreciate everyone attending.
Thank you. I'll see you later.